everyone, to the AI Oncology Revolution, and thank you so much for being here. For those who don't know me, I'm Dr. Arturo Loaiza-Bonilla, and a medical oncologist, an AI enthusiast, and I'm here to have a great conversation with Dr. Matthew Matasar, who is the Chief of the Division of Blood Disorders at Rutgers Cancer Institute. Welcome.
Thank you so much, Arturo. Thanks for having me today.
Of course. So we would love to learn more about yourself. Just tell us, about your practice and things you're doing for those who may not know you.
So by trade, I would say I'm a lymphoma guy. Certainly, my clinical and research interests have focused around questions about lymphoma. At Rutgers, I also serve as our division chief, so I have some more broad oversight over questions of blood disorders, the blood cancers, leukemia, lymphoma, myeloma, as well as our transplant and cellular therapy programs.
Well, thank you. As you may have heard before, my brother was diagnosed with leukemia many years ago, and so I appreciate folks focusing on that specific because it's not easy. It's not easy to have, the management of those patients and also the evolving field that happens. So
it's not easy, but it's the work that we do is an honor. What we do is very, very special, and I always see it as a privilege.
So talking about your research interests and things that you're doing at Rutgers, tell me more about what you do on a daily basis and what your fellows do, and what are the things that you feel are helping us to advance the field further.
So we're the only comprehensive cancer center NCI designated in the state of Jersey. So we're sort of a soup to nuts major academic program that focuses around cancer diagnosis, cancer detection, cancer therapy, and certainly advancing clinical research. There's a lot going on research in the area of blood disorders. Obviously, we're in a very interesting moment in clinical research and advancing care with this proliferation, particularly of potent immunotherapies in the diseases that we treat. The proliferation of novel CAR T-cell therapies, bispecific antibody therapies, enhancements to our ability to deliver allotransplants safely and effectively. We are squarely in the era of immunotherapy, and it's been a hell of a ride.
Yes, a lot of things happening, and knowing that, CAR Ts that were a novelty before, now everywhere, and now we're even seeing them in solid tumors, and so now folks like myself were learning how to manage those side effects as doing, I'm a GI oncologist by trade, so, but see our patients going and getting those treatments now as a therapeutic option. So today, as you know, this is the AI Oncology Revolution. We're talking about AI in oncology and in hematology, of course. And we haven't had the chance to talk to actually someone like you, who is a hematologist who has all this expertise in that field. So where do you see the field evolving in AI, and has AI touched your lives and things are happening?
So it's a super good question, and it's very interesting, right? So you can think about what AI is doing for us right now, and you could think about what we think it's going to be doing over this next year, and what's our aspiration for what could AI offer us in the future. The question you ask of, is it already touching what we're doing? The answer is absolutely. Mm-hmm. AI is already here in the oncologic world, and you know this as well as I do. It's already affected in a foundational way what my radiation colleagues are doing, and they're already incorporating AI-based simulation into their radiation oncology planning. Modern radiation oncologist without AI is not a modern radiation oncologist. The surgeons are a little bit closer than we are, I think, and there's a lot of very innovative work in trying to deploy AI augmentation to the surgical approach to the treatment of solid tumor malignancies outside of my scope. But I listen with great curiosity, and it's fascinating to see what they've achieved in a very short period of time. In my world of blood disorders, what are we doing with AI right now? I would break it down to what are we doing in clinic and what are we doing in research. In the clinical space, we're already using AI LLMs in our tumor boards. And particularly these so-called RAGs, right, retrieval augmented generated systems like DocsGPT or like Open Evidence, these systems that are a little bit more of a walled garden where they're drawing on true clinical data, knowledge, and evidence, and then using that to draw upon and offer clinical guidance or insights. We're running them as part of our tumor boards. Yesterday's tumor board, we had a patient who was being prepared for a stem cell transplant who had identified an early stage breast cancer in the evaluation. Well, what's known about that? What's the modulation of risk for breast cancer recurrence following an allotransplant? 2 years ago would have been, let's ask our senior-most transplanters what their experience has been. And they've been doing this a long time and have transplanted hundreds of people. We can do better, and you can generate far broader and quicker insight into whether this finding is going to modulate this individual patient's treatment course in a way that gives the whole team and the patient greater confidence in moving forward or not on the basis of firm foundational evidence.
No, I agree. And I think there's so much knowledge happening every single day. And for those unique cases that we may not have the expertise because they're so rare. And there may be some study somewhere that someone actually found and tried something, but we didn't have that information in front of us. So, so I agree, and having this information coming to us, particularly when it's grounded in evidence, I think is key. So for those in the audience who are not as familiar with RAG, is retrieval augmentation generation, which is basically after the model is trained, they're able to use ground truths in terms of data. So journals, as you mentioned, could be ASH or any of those sources, and integrated into questions. The key is the prompt by an expert like you. So, so that's the key part of it, and that's why it's so important on tumor boards to make sure that it's focused on a patient. And I appreciate that because I don't think a lot of folks are doing it right now in real time. Some folks may have software that does some of those efforts, but not in a proactive manner. So I think something that the folks who are listening to us or watching us can probably take advantage of.
And I would encourage doing just that. Yes, you have to be cautious. Not all systems are HIPAA compliant. Please, caveat emptor. Mm-hmm. But, we are oncologists, and we're trained to use every tool at our disposal in the service of our patients. And these are very powerful tools that are available in the here and now.
Yeah, so, and if you could look at all those tools, so if someone is saying, okay, I want to try this out, what do you feel has to be the value that those tools bring to them so they can feel more confident about using them?
I think the first thing to do is just to take the leap. You don't need to invest your decision-making into the LLM, right? You can just say, hey, this is what our tumor board generated out of it. What would happen if I popped that clinical scenario into DocsGPT? What would it have advised us? We're actually interested in trying to run a prospective trial, asking just this question, where let's run our tumor boards and let's run more generative AI models that are free-thinking, like Claude or Chat or whichever one you like, and let's run RAGs as well and see what those opinions are. You could then take those and you could offer them to external blinded experts and have them assess the case and assess the recommendations and qualify those results. There's ways that we can try to study this rigorously and prospectively, but for now, just start doing the work and get experience with what these models can and can't do to support your practice, and I think you'd be surprised.
No, I agree 100%. Kind of like being a little bit more, look in the future. So there's some interesting models, and I think we spoke briefly about them. So for example, someone looking at a retinal exam and seeing based on the size of the blood vessels, predict potentially the appearance of a malignancy, hematological malignancy. That's to me is like science fiction.
It really does feel like sci-fi, doesn't it?
So, but there's other more contemporary ones like digital pathology, making diagnosis based on that. Have you seen some of those efforts, for example, presented at ASH or some places? And is digital pathology something that you feel is going to be part of our workflows in the future?
So we sort of talked about like the here and now, the near future and the distant future. Yes. Digital pathology is the here and now / near future, especially in my world of hematologic malignancy, where we know that diagnostic precision is both critical to outcomes and also extremely heterogeneous. Mm-hmm. Even looking back just at comparing expert hematopathology opinions versus community-based hematopathology opinions, expert second opinion review alters a diagnosis in a way that changes guideline-based management 1 in 5 times. Wow. And that's just comparing expert with an individual brain versus a general pathologist with an individual brain. There's no way that incorporating AI-based approaches to pathology is not going to further enhance our diagnostic accuracy and precision. And we know that that's going to lead to better outcomes. It's not only obvious, it's critically needed.
Yeah, and I just see that the implementation is so scattered around, right? So I think that there has to be some form of, commons where people come together and say, let's set up some frameworks of how we're going to implement this more robustly across different health systems, because everyone's doing their own thing. Yes. So you see Mayo Clinic doing something, Memorial Sloan Kettering doing something else, Rutgers, St. Luke's, we have our own AI governance. But I feel we need to have a much more close relationship to really make this much more generalizable and robust.
I really think this is where our societies can really weigh in effectively, whether it's ASCO or ASH or even the AMA. I think that we can lean on our collective voice to really try to help define what our priorities are, what our tolerances are, try to define what we see as the good and how do we get there.
If you had, looking at a patient or a number of patients that you treated in your cancer center, what would be your wish list for AI to solve now and in the future?
So right now, what are we doing with AI in the clinic? Yeah, we use AI scribes. That's fine. It's a cute enhancement. It saves me a few minutes of time on patient. The notes it generates are actually quite excellent, I'll admit. Is that a game changer? Obviously not. We're using it to help identify clinical trial participants and to do some of the work in trying to ease the burden of matching patients with trials, work that you're intimately expert in. We could do better at that, but we're already dabbling in that work, as are many. But I think that it's going to become a very powerful tool in our pockets, just as our own individual knowledge base, expertise, training, judgment. I think that we're going to find ourselves in the near state where we're turning to AI-enhanced clinical decision-making. AI is not going to replace oncologists. AI is not going to sit with a patient and hold their hand and talk to them about the risks and benefits of the approaches that are available to them. But it's going to position us as oncologists to be better at what we do with our patients.
You had mentioned that there were some tools that you're already using at your institute. And can you tell me more about those?
So the first thing that we're doing is, of course, is trying to incorporate using RAGs inside of our tumor boards. The second is we're incorporating AI scribes of limited utility, but we'll take the win. We're using models to try to enhance our clinical trial identification pipeline and accrual, where it will embed within our electronic medical records and help identify patients who could be eligible for trials that may not otherwise be identified by their clinicians. We are a large health system, 14 hospitals across the state of New Jersey, over 2 million lives covered. There's a lot of doctors in that system who may or may not have as intimate awareness of the full clinical trial portfolio and inclusion-exclusion criteria. And having an AI-embedded approach to help those doctors identify clinical trial participants can only help both fuel scientific discovery as well as enhance patient outcomes. So these are the ways that we're using it right now, and we're super excited to find better ways to leverage it in the near future.
Yeah, so have you seen any tools for deterioration of,
You're prompting me, thank you. So outside of my own little field within blood disorders, the RWJ University Hospital recently published in JAMA a work using an AI-embedded model within EPIC, not focused specifically on oncology, but on internal medicine, called a deterioration index, where it's able to, within EPIC, draw from individual patient data points and apply a sophisticated and dynamic model to identify which patients are at risk for deterioration, flag those patients, and initiate deterioration interventions to try to preempt further clinical deterioration. We demonstrated against historical controls in that work led by colleagues that the intervention is extremely successful at trying to improve and enhancing patient outcomes in the inpatient hospital setting.
Yeah, and I think that those are like the really very good use cases that we can demonstrate now. And so just curiosity, so I also have Epic in my health system, and there's this, little chatbot called Art, right? Which is like Arturo, like me. But sometimes patients make questions into the inboxes. And I mean, I can say personally, it's becoming really helpful. Because for example, there was a question of a patient asking, hey, how can you tell me how my PET scan went? Should I do something about my surgery? And I was like, I knew the PET was there, but it was able to pull out the latest PET scan and gave me a initial answer and actually modified it and sent it out. Have you seen any value in that to make our lives easier responding to patients, or not yet?
I'll admit that I hate their answer prompts. I'm very fussy about how I answer my patients.
Right.
For better or for worse, I feel like I have a specific voice when I'm communicating digitally with my patients. And I haven't been comfortable using the voice of that system in their responses. But I know that colleagues are, look at that differently, and I think it's going to get better. Certainly, we use AI for helping with our documentation for patients all the time, right? I haven't written a letter of medical necessity since I couldn't tell you when, right? That's purely AI done at this point. Return to work letters, some of these daily chores that burden our teams as much as they burden us are so easily and fluidly done through AI approaches.
Yeah, exactly. So whatever we can do, I call it the Moravec's paradox, right? Like machines can do a lot of the clerical things that we don't want to do, or there's really not important for us to be involved. So we can go back to the patients. And in your particular case, I mean, of course, I do with pancreatic cancer and other cancers that are very tough too, but there's a good reason why hematology is such an interesting field, because there's so much stuff that you have to go through. So,
yes. and the information proliferates at an incomprehensible pace. There's no way that even the best read oncologists can keep track of everything.
Thinking about what other colleagues have said about AI, what have you heard them being excited about, or have any comments that you see in the field, particularly not only in your institution, but like you're an extremely well-known individual, talks to a lot of people, very personable, as you can all tell. So you'll have to tell us more about that.
I think that we're sort of in this embracing the dialectic moment where we have all of this real deep-seated optimism about the potential of AI as a transformative approach, and we have all of these misgivings. What are we doing, and how are we influencing and changing our profession, our career, and is there a downside that we don't yet appreciate? The potential is really extraordinary. We have, not yet in oncology, but we have the first drug that's gone from an AI model detecting a new target to AI designing a molecule that could hit that target, to phase 1, phase 2, now a phase 3 trial. This is in pulmonary fibrosis. So AI is going to, and is already changing drug discovery, which can do nothing but benefit our patients. Accelerating discovery, making discovery cheaper, democratizing it. The potential there is really incredible. We've talked about some of the clinical applications, but what do we lose? This is what I hear from people: is what is our career going to look like in 10 years? When AI is more mature and more robust, and are we going to be steering AI, or will AI be steering us? I think there's a lot of misgivings and uncertainty, which makes sense. This is transformative, and transformation is both thrilling and unsettling.
Yes, and I always feel that it's all about us kind of becoming adaptable, and that's what the resilience and adaptability of humans comes along with that. So there could be this Jevons paradox, which is the paradox that is not going to be replacement, but actually even more need for us, because we're going to be able to spend more time, going to make more diagnoses, going to need more of us, and that's why AI can help us, and it becomes a collaborative intelligence, which is my hope, of course. And I think driving these conversations is what's going to help us to get there. I'm happy to be replaced if we can get rid of cancer forever.
So from your mouth to God's ear.
Exactly. So we all be happy to be replaced by any AI tool that actually can cure cancer, but we're really far away from that. So for now, what we can do is just try to use them to make the life of our patients better, and hopefully ours too. Less pajama time, so we can spend time with our patients and families. Do you have any final remarks about the AI on the positive end of it?
I would just end with my optimism, right? Like if you look at where we're at now versus where we were at 3 years ago, where AI was looked at with pure skepticism and discomfort, we're already finding incredibly nimble ways to incorporate it into our practice. The shape of the curve is clearly, incredible, right? The speed of development of novel approaches and novel abilities. We don't know what the future is going to have, but I guarantee you that it's going to bring us better approaches and better tools for diagnosing and treating cancer, and I'm here for it.
No, well, so excited. So, well, thank you so much for the opportunity to be here and talking to you. So this is the AI Oncology Revolution, and looking forward to seeing you again in a future episode.
Thank you so much, Arturo.